I wonder if you are live. I think we should start our session about the first cataract session in the conference. We'd like to thank Dr. Mohammed Al-Amri and the scientific committee for putting up this big meeting and so many scientific subspecialties. And I'm privileged to know that we are going to discuss how to manage challenges in cataract surgery. And I'm privileged that I have my co-moderator, Dr. Ashraf Armiya, and great experts of anterior segment surgery, Dr. Kathleen Maccabi, Professor Mahipal Sajdev, Dr. Rajendra Prasad, and we are going to talk about some of the challenges that we meet in our daily work. And it's very important that we get the proper idea of the experts teaching so we can have a reproducible technique to deal with such challenging cases. And this is the whole idea of this types of meetings, that we transfer knowledge, we all learn from each other. And it's very important that we take the message clearly. We don't have to reproduce exactly everything, but we have to understand the concept and the idea of how to tackle such difficult cases. So as not to waste more time, we are joined already by Dr. Kathleen Maccabi, who's going to talk about flanged Prolene solutions for cataract surgery, which is a very interesting subject. Hello, Dr. Maccabi, and we are looking forward to hear your talk.
I'm delighted to be here. Thank you so much for the invitation. And I'm excited to share with you some of the things that I've been doing with some of these complex cases. So let me see if I can share my screen.
And we will try to manage the time as much as possible so as not to encroach on the next session.
Yes, all right.
Have time to discuss, okay.
So we're going to talk about, thank you so much again. I want to thank you for the invitation to be here with you today. We're going to talk about flanged Prolene solutions for cataract surgery. And I'm going to show you a particular case where it was very helpful. And I think sometimes cases are the best way to illustrate this. So this was a 73-year-old woman. She had a history of blunt trauma to her left eye 5 months prior when a set of keys was thrown and hit her in her left eye. And you can see she wasn't seeing well out of her left eye. She also had a cataract in her right eye. There were transillumination defects all the way around the iris. She had a traumatic mydriasis and a zonular dehiscence that was more than 180 degrees, which you'll be able to see here in a moment. All her other tests were normal. You can see here that we've done an IOL master, we have a plan, and some of the things with these kind of cases is you really want to be prepared. You want to have the appropriate anesthesia, so sometimes general anesthesia, but definitely a retrobulbar block if you're going to be sewing something in potentially. You want to make a very atraumatic capsular axis, maybe bimanual in these cases, or femtosecond laser tends to be my go-to. You want to have several plans for placing the IOL. Maybe you're going to try to retain the capsular bag. That's usually my #1 plan, plan A. And that will require some capsular hooks and support, maybe a capsular tension ring and segments that you'll sew in. You want to have a 3-piece backup lens, maybe a Yamani technique, or even putting a CTR in the capsule and then capturing the optic. And that's been described in really a very effective way as well. And be prepared for an anterior vitrectomy, having intraocular steroids and antibiotics available. I wanted to talk for a minute about plan B, which was putting it in the sulcus and capturing the optic. There have been a series that have been published on that. I use this technique a lot when I don't have other resources. So on mission trips, I think that's really a nice thing to have in your back pocket. Now I am going to sort of, we have a lot of sound with that, but this is actually the image of our patient. You can see that there's a gap. I don't know if you see my cursor, but there's a gap between the iris and the edge of the lens. And if we look at that scan on the linear scan, we can see there's just a big space here between the iris and the edge of the anterior capsule on one edge, very tilted implant, and then it does touch the edge of the capsule on the, or the iris on the other side. So here's the actual patient. This is the surgery. You can see that scalloped edge. That's always a bad sign that something's going on over there. It's hard to appreciate that it's tilted here, and sometimes it's hard even in the surgery itself. I've marked 2 millimeters posterior to the limbus. And in this case, I'm going to use a technique that is going to be the permanent support for my capsule from the very beginning, kind of using it in place of a capsular hook on this side. So what I'm doing is taking a capsular tension segment. I put a section of 5-0 Proline in there, made a large flange, and made sure it didn't come through the eyelet. You can see just how unstable this is. Just from the force of taking that capsule, it's already pre-cut out. There was a lot of movement of the lens. I am going to put some capsule hooks on the opposite side just so I don't damage those zonules as well, the ones that are intact. Now I've placed the needle through conjunctiva and sclera into the sulcus. This is a 30 gauge thin walled, or actually a 27 gauge needle that's been bent. I'm taking the cut end of the Proline suture and I'm feeding that into that Proline or into that needle. I'm going to withdraw it so it goes into the sulcus. And now it's gone outside of the eye through sclera and conjunctiva. You can see it there, 2 millimeters posterior to the limbus. Now I've taken microforceps and I'm introducing the capsular tension segment into the anterior chamber. There's that large flange through the eyelet that's going to support that segment. And I'm just going to start out using that as my support system for the entire quadrant. And really it's 180 degrees that we have such poor capsular support there. And you can see that lens just dips over there. I'm trying to be very careful because I don't want to do anything to the intact capsules on the opposite side. And actually just to make sure that I'm not doing anything, I put a second capsule hook in there. And then I can cinch that up some so that it's nice and planar and supporting the margin of the capsule where there are no zonules. The rest of the surgery is going to go very slow with low settings and low flow settings. Fortunately, this is not a very dense cataract, and I'm able to really use very gentle techniques with a lot of dispersive viscoelastic to elevate those pieces, bring them into the anterior chamber away from that floppy capsule. And in some places, once we get the majority of this out, always putting more dispersive viscoelastic and reinflating the bag. And you can see there's really significant zonular loss here. But I'll be able to even aspirate and irrigate some of that material, especially the epinucleus, very atraumatically without really putting a lot of stress on the remaining zonules. And I think that's key in these cases. You don't want to rush the removal of the nuclear material, epinucleus, and even cortex, because you can put undue stress on these already stressed tissues. And again, my goal is to keep the capsule if at all possible. I'm irrigating out some of the remaining nuclear material. And then once that's clean enough, I will actually go ahead and put a CTR in. I like to do this two-handed technique. This is a preloaded CTR. If I put a Sinski into the eyelet and have an assistant advance the plunger, this is a very, very atraumatic way to put this in. I'm not putting any undue stress anywhere. And again, I can maintain as many of the healthy zonules as possible that are already there. So that now has expanded the bag. You can see that my capsular tension segment is in a good position with the right amount of tension, really being careful to remove the remaining cortex, but you can do that even after the CTR is in place and even with capsule hooks in place. And once that's all cleaned up, I'll be able to put in my choice of a lens. In this case, I'm putting in a single piece hydrophilic acrylic lens. I'm doing that because it has 4 closed loop haptics. And with the CTR in there and those 4 closed loop haptics, I know that if this doesn't work out long-term as I hoped with enough support, I have lots of opportunity to support it with additional suture. It could be Proline suture, could be Gore-Tex suture, without having to exchange the lens. So this is going to go in there. I kind of like this lens sometimes too, because it expands very large, almost acting as additional support inside the capsule as well. And I can take out my capsule hooks, see what I think the integrity of that other side that hadn't been affected by the initial trauma, and see if I need to put another capsule tension segment on that side. But everything looked good. It was nice and centered and stable. And this case was able to retain the capsular bag with good support and I'm already done supporting it because the support system I used for the whole surgery is also the long-term enduring support that the patient will have. So that's kind of that case. And I just wanted to touch on a few points. Now I'm going to go forward just so you can see. I do put triamcinolone in there. Right now I'm just taking some strands of vitreous that came around. They were like little wisps. I stain it with the triamcinolone. I like the fact that there's some long-acting steroid in there, but you can see just how stable that lens is. Really nice and stable at the end of the case. So surgical pearls for these types of cases, really important to have a nicely sized and centered intracapsulotomy, and the use of capsular hooks and segments in a CTR are important. And it is possible to use that sulcus placement with optic capture that I mentioned, if that's something that you need to do. You want to minimize nuclear sculpting and rotation, use careful hydrodelineation, low flow settings, frequent and liberal use of dispersive viscoelastic, inflate the capsule, use intraocular triamcinolone to stain vitreous, and intracameral antibiotics. So here's our patient. She was doing great. She does have a little bit of traumatic mydriasis, and in hindsight, I should have put in a four pass pupilloplasty. One single suture would have helped. There's where that proline suture is, nicely buried into the superficial sclera. Patient was really doing fantastically in that eye. She's super happy. And for this technique with proline suture through a capsular tension segment, fibroproline works best because you can make a large enough flange. Low temperature handheld cautery creates the flange. And Canabrava has shown this technique too. Here's Tom Oding using it and doing a little different technique, passing first the proline suture, then externalizing it and putting it through the CTR. So you can use it at the end of the case. That's typically how it's shown, but I thought that perhaps placing it in the beginning of the case would save some time at the end. And I think that that worked out well for this patient. And again, the really critical thing is burying the flange sufficiently in the superficial sclera, because there have been reported cases of erosion and endophthalmitis with flange techniques. So you want to be sure you do that. So thank you so much for your time. And it's been a great pleasure to be here with you all.
Thank you, Dr. McCabe. Superb surgical technique, superb illustration. And just a rapid question that is there a problem in embedding or burying the knot of this? You're using 5-0 proline, right?
Yes.
So what's your tip? What's your tip for burying properly the flange?
Yeah, that's a really good question, because at first I thought, I just don't want that to pull through. So I always made a very large flange. And the truth is, you don't need to make a large flange. So I'll trim it again right before the end of the case and make a small flange that's easily buried within the posterior or in the superficial sclera. They're a great point, though.
Thank you so much. I think we'll move, and hopefully we'll have some time for more discussion at the end of the session. Now it's my turn to talk about the secret of hard cataract, phacoemulsification that we see a lot in our region. And hard cataracts can present in different ways: the brown cataract, black cataract, intumescent, Morgagnin, or hypermature cataract. The challenges that we face are difficult capsular axis because of poor contrast, difficult nucleus management because it's thick and hard, and risk of posterior capsular and corneal complications. The idea is that we want to have a reproducible technique to convert a difficult case into a regular case, like we are used to do all the time. So let me talk about the problem of capsular axis and tumescent cataract, which is a challenging thing that in such cases, I'm sorry. This is staining under viscoelastic, which I usually do, and in such cases there is high pressure inside that tends to get the capsular edge.
Doctor, can you share the screen, please?
Share the screen.
So in tumescent cataract, we need to deal with the capsule, avoid extension, and the famous Argentinian flag sign. The idea is that I do staining to overcome the bad contrast, and I do the staining under viscoelastic. I just paint little of the capsular stain, and then I remove it. And then the trick here is to do a curved incision, so as when you go out to aspirate some of the cortex to deflate the back, you don't have an extension to the periphery. Actually, if it extends, it will extend where you go. And you move regularly as usual, keeping the pressure in front and behind of the anterior capsule regular, the same, equal. You can repeat the maneuver of aspirating to restore this condition. You always need to control the capsular axis so as to make it as wide as you want and the shape that you want. You have to be just careful. In cases of Morgagnian cataract, the difference is that once you open the bag is deflated, but then there is loss of tension inside and the nucleus actually wiggles. So you have to overcome this by injecting a viscocohesive material into the capsular bag so as to be able to gently control the tear in the anterior capsule. So this is a different challenge in hard cataracts. And how to look for the nucleus challenge, the nucleus is hard, so you might think you need more ultrasound power. You definitely will need more time, but you have to think where you are doing the ultrasound. And the nucleus being hard is difficult to crack, so giving the misnomer of gummy nucleus. So I want to dismantle the nucleus challenges. I don't do hydrodissection in such cases because I don't see the wave, and consequently, I don't to avoid capsular Brock syndrome, I don't do hydrodissection. You need good tip exposure and maybe use wider tip, make a wide groove to facilitate chopping. Use two nuclei concept, which I'm going to elaborate soon. Work on the posterior chamber away from the cornea. Protect the cornea with viscoadhesive and watch small intraocular bubbles. Interrupt ultrasound use to avoid corneal wound burn and do vertical chopping with maximum vacuum least power. The two nuclei concept, the idea is that I want to change this thick nucleus into a regular sized nucleus. The first part, I shave the upper superficial part of the nucleus with the tip beveled down, so to decrease the propagation of ultrasound energy to the cornea, and with very good tip exposure. Then once I reach the depth I need, I turn the bevel up. Then I do exactly what I need to do as I do usually. And then you make a good well, a good groove. Doesn't have to be long, it has to be wide and deep, so as you can go and shave as deep as you can to be able to crack the nucleus. And in very hard nucleus, I do what I call hole drilling to weaken this wall of thick nucleus. Let's have a look how this works. This is the good exposure, bevel down, shaving. I use the Neuhann chopper, debulking the upper part. The whole idea here is that you want to see what you are going to do. And to see well, you have to have a wide groove, so as you can shave as deep as you can to be able to crack such a hard nucleus. The common mistake is if you do a regular groove, then you're afraid to go deep enough, so you don't crack properly, and you think of what people say, it's a gummy nucleus. Now you can see I'm shaving, going deep, and now this is the hole drilling. You just, with the ultrasound here, I'm using 70%, for example, ultrasound. Just with the exposure of the tip, you drill holes all around, 360 degrees. This weakens the strength of the nucleus shell, and it has no harm on the cornea because you are completely embedded into the nucleus. Then with this well, you can chop and split the nucleus, and you have to follow the crack line. See the crack line? You have to follow this crack line to make sure that the fibers splits completely. You cannot do this if you don't have a wide crater inside to see what you are doing. You have to be patient, but the main player here is the vacuum. You are using very little ultrasound in this stage. 40%, 3%, 30% according to the hardness of the nucleus. But the main player is ultrasound. You are protecting always the tip with the nucleus with good engagement, feeding with the chopper. So this slices the nucleus into smaller pieces, and hence there is no need for ultrasound. And you can judge your post-operative result with, at the end of the surgery, seeing how the cornea is clear. Just follow the steps. The same thing is applied even in intumescent cataract. Just want to show you, look at the power gauge here and the vacuum gauge. You have to see the splitting of the nucleus. If you don't split it properly, you cannot disengage it and you cannot remove it. And try always to work in the posterior chamber. It doesn't matter how long it takes, but the most important that you work away from the cornea. And you can observe the fine air bubbles that are entrapped with the viscoadhesive, viscoelastic that we use. It entraps some viscoelastic, some air bubbles, fine air bubbles that you can see. If they are not moving, you are safe to the cornea endothelium. Look, the vacuum is the main player. Everything is done under vision. And with this technique, you can even work in smaller pupil sizes with no need for iris hooks or other pupil dilating instruments, because you work always in the center. And you are always protecting the cornea by working in the posterior chamber using very little ultrasound power. And don't worry of embedding the tip into the nucleus, because this saves the cornea from unnecessary ultrasound and give you great holding power, because you engage and you will not perforate through it because it is really thick. Using the second hand to feed and split the nucleus into smaller pieces while holding the bigger piece with the vacuum is extremely useful to decrease the ultrasound power, which is in such cases is very important because the surgery takes longer time and you really don't want to insult the cornea. So in conclusion, hard cataracts are challenging, but it is not only about removing the cataract. Don't focus only about removing the cataract, but more it is about removing it safely. Thank you for your attention.
Dr. Yahya, can we stop sharing? It's amazing surgery. The very hard cataract is always challenging, and the beauty of what you was doing. I was watching that the phaco tip was always in the center, and the pieces are coming to you. This means the good fallibility of the machine, and the you are using the flow rate and the vacuum in a very stable way. Because instead, if it's a very hard cataract, usually people go to the piece, but the pieces, the phaco tip is in the center, is stable, steady, and the pieces are coming to the tip. And this is the beauty of this, the surgery you presented.
Thank you, Dr. Ashraf. I think we can...
Yeah, we can proceed to the next presentation. I think Dr. Mahibal.
Yes, thank you. Thank you very much. It's indeed a pleasure being here. I'll be talking about the use of femtolaser assisted cataract surgery for posterior polar cataracts. Is my slides and everything visible?
Yes. Yes, perfectly visible.
Good. So as we all know that posterior polar cataract remains a challenging situation to the best of these surgeons, because there is an incidence of posterior capsular, pre-existing posterior capsular weakness, which is there in posterior polar cataract. Now, this pre-existing weakness in the posterior capsule when you're doing cortical cleavage, hydrodissection can cause a hydraulic rupture of the posterior capsule. However, if you are doing a femtolaser assisted procedure, there is a pneumodelineation that happens because of the bubbles that are created, and this eliminates the need of hydrodissection or hydrodelineation. Now, the second important thing is that you get a great capsulotomy, and in addition to that, the femtolaser enhances the nuclear disassembly, and you can get minimal turbulence that you get when you remove these nuclear fragments. So the points that we have to keep in mind when we are dealing with a posterior polar cataract is that we should preferably work on a closed chamber. We should be using slow fluidics. The advantage that I'll be discussing is of the presence of the ASOCT, which is there, and as to how it helps us work in a posterior polar cataract. Getting a perfect capsular axis that can help us place the lens in the sulcus, careful hydro procedures if at all required, and having an epinuclear cushion right till the end when there is a pre-existing posterior capsular defect. Now, let me show you the image on, this is the catalyst system that we are using. This has a high definition anterior segment imaging, which delineates the anterior and posterior cornea and lens borders. And when you look at these anterior and posterior lens borders, you can see at this particular point that there is a pre-existing defect in the capsule that can be made out very well. So therefore, you can use the customizable offsets to actually create an epinuclear cushion that can be there right till the end of the procedure. Now, let us just see this, what we are doing. So you have these three bubbles, and you can see that this is a pre-existing capsular defect. And what we are going to do is that we are going to raise this so that the area where the emulsification happens, or sorry, the femto breaking of the nucleus happens, leaves behind an epinuclear cushion. So this is what I showed you, that this is the pre-existing defect, and you should raise the offset so that you are able to use the epinuclear cushion to prevent the posterior capsular rent from happening earlier. Now, these are various authors who have written about the application of anterior segment OCT, which could identify posterior polar cataracts. And what we have shown is that if we use the ASOCT during the surgery as to how it is going to help us, and this paper has been published in the Journal for Cataract and Refractive Surgery, where we have shown the specificity and the sensitivity to detect pre-existing posterior capsular dehiscence in cases of posterior polar cataract when we are doing a femto procedure, and as to how it increases the safety. And we have not had a single nucleus drop in any of the cases of posterior polar cataract where we have used the anterior segment OCT to guide us on the treatment modalities. Now, let me just show you that again, as to this is a patient, you can see very clearly in this particular case, this is a slit lamp picture, and you see that there is a polar cataract and there is a huge dehiscence that is available right from the beginning. Now, this is going to be a challenge. And in these particular cases, if we use a femtosecond laser as to how we are going to help. So you can see here, this is the catalyst system. We are doing the docking. And you can see again in this particular case that this is the area where there is a dehiscence, which you can see very well. Now, what we are going to do is that at this dehiscence, we are going to raise the default. So you can see this default, these bubbles are going up and we are raising, so that again, as I mentioned, that we will leave maybe about 1400 microns of the safe zone. And this is the capsulotomy we have, and this is the nuclear. So you can see that this is the nuclear disassembly that we have, the fractionation. You can see that that is the defect that is available. Now I'm using an intra-op OCT, and you can see that this is the defect which is there. Can you see this? This is the defect on the intra-op OCT. Now I am not doing any hydrodissection that I have done, and I am able to take out the nucleus. You can see that this defect is visible as you right here. You can see this is the defect that is visible on the intra-op OCT, and gently and slowly, maybe it would be better to do a bimanual. But you can see gently and slowly without letting the deflation happen. And that's a big rent that has come. There is a vitreous which is here, which is there. And then we put in a lens, and you can put a 3-piece lens, and you can see post-operatively, this is a good outcome that we have. So this is, and you can do a capture of the lens into the anterior capsule. So this is just the same video that I showed you. This is the photo essay. This is the slit lamp picture that we have. This is the microscope integrated OCT that we had. And you can see that this is the OCT that we saw on the catalyst system. And this is the nuclear fractionation that we did. This is the rent that you can see after we have cleared everything. And this is the vitreous bulge that is there and the intact vitreous which is there. So the femto essentially gives you perfect incision with good architecture, closed stable chamber with no fluctuations that are there. And the rexes that you have, it is a boon if things go right. And if it is it's a blessing if they don't, because you can use this anterior capsular support even in the presence of a posterior capsular rent, which is well centered, exact size, and you can do a capture of the IOL haptic, IOL optic into this particular thing. The nuclear softening, as I told you, there is fractionation and softening that happens and therefore makes the emulsification very easy. Nucleus rotation may not be needed, as I showed you in this particular video. This is another technique that has been shown by Dr. Vasavada, where you could make these concentric rings, and again, femtodelineation, hydrodelineation, this can happen, and you can leave a thick posterior offset and go ahead and do the procedure. So the epinucleus works like a shield when you go out to fight the posterior polar cataract. It can be precise, sharp, but also gives you a smooth pneumodissection. Posterior limit of the nucleotomy will go up, and it could be about 1,000, 1,200 microns, depending upon as to how big your rent is. And this thick epinuclear layer would act like a shield for the weak posterior capsule. So you do not disturb the vitreous in almost all the cases if you follow what I have shown you. And nuclear rotation need not be done. And if it is required, only the inner concentric nucleus can be rotated without disturbing the posterior capsule. So femto laser assisted cataract surgery, I would say, takes you away from the dangers of a normal phacoemulsification in a polar, and it gives you the necessary cushion and the airbag to get you safe back home and without having nucleus drops and getting good outcomes with minimal nucleus disturbance. Thank you very much for, sorry, this is the last. So this is, again, these are the numbers that have been shown. Dr. Vasavada, he had a rate of 36% of PCR rent when it was normal phacoemulsification, and going on to flax, it went significantly down. Bob Osher, 26%. Dr. Titial has reported 0%. And as I told you, we have had no nucleus drop in cases of posterior polar cataracts that we have worked on with the femtolaser assisted cataract surgery system that we are using in a lot of our cases now. So to sum up, posterior polar cataracts can be a nightmare for even the most experienced of surgeons. However, the anterior segment OCT, that is an integral part of the femtolaser, can be used to preoperatively determine the status of the posterior capsule and helps us prepare whether we are going to have a posterior capsular rent which is pre-existing or not. And flax provides the much needed safety cushion. And I would say that it is the way forward. This is like the first presenter showed in subluxated cataracts, where you get a good capsulotomy. I think posterior polar cataract is also the best way forward, is to go ahead and adapt a femtolaser assisted cataract surgery. Thank you very much for your kind attention.
Thank you very much, Professor Sajdev. It's very interesting, very important message. And I think the paper you made about the accuracy of the OCT, anterior segment OCT, for diagnosing the posterior rent in posterior polar cataract surgery had enlightened us, because there has never been before a tool that we are 100% sure that there is a rent or not. So this really was a great input and addition to our knowledge. And your technique is perfect, but I would like to ask you about, for those who doesn't have a femtolaser, what's your advice as regards the technique?
Okay, so the point is that we have just concluded a study, and we'll be sharing that you can also use a swept source OCT if you have in the OPD. or also even the IOL Master 700, where you can possibly detect whether there is a discontinuity of the posterior capsule or not. So that is, you need to be prepared, because in cases there is a pre-existing rent and onion whorl appearance and slit lamp examination. So all these are very, very important, even if you don't have a femtolaser, to do a critical examination to see whether there is a pre-existing defect or not. If there is a pre-existing defect, I always do the patient under peribulbar. I have my vitreoretina colleague being available, and I tell the patient, and I always have a 3-piece standby intraocular lens that is available. No hydrodissection, no rotation, good capsular axis support. These are the important things. And as I told you, you should have a controlled phacoemulsification with low fluidics, and move minimum the amount, and the rotation should be minimum, and try to leave behind the epinuclear cushion. So here again, no hydrodissection, but hydrodelineation is something very, very important. And majority of the time, posterior polar cataracts are not very hard. The other thing is, always look at the other eye. Sometimes the patient don't tell you, and if you have an anterior chamber lens or a scleral fixated lens, or you have evidence to see that there is a PCR or a vitreous loss that has happened, it is likely to get repeated in the other eye. So these are the basic principles that are there, and imaging techniques of even using a good OCT that you have in the OPD can help you guide this. And there is very little difference between the OCT that is on the femtolaser versus a good swept source OCT that you can have in the OPD.
Thank you very, very much. And maybe we'll have another other questions at the end of the session. Now we move to Professor Prasad. Last but not least, talking about a very important topic, which is soft cataract, and which there are controversies. Should we let our residents or juniors start soft cataract? What are the difficulties? How to make it a reproducible and safer technique? Please go ahead, Professor Prasad.
Yeah. Okay. I hope you can see my screen now.
Yes, we can see it perfectly.
Thank you very much for the nice introduction. And first, I would like to thank QOIC for inviting me here in this beautiful session with the legends in the ophthalmology, Dr. Maipal, Dr. Yaya, and Dr. Asha. Thank you very much. And I thank Dr. Mohammed also for giving me this honor to be here with all of you. So the topic which I'm going to talk about is the very simple topic, the topic which we normally come across in our day-to-day practice. Most of the soft cataracts have started coming up because of the lifestyle change, early cataract surgery. People are looking for the refractive cataract surgery and the lens exchange just for the correction of the vision. So many of these soft cataracts we had started coming across in our clinical practice, and more and more are yet to come with us. So the point is, like these rock hard cataracts, we have been putting a lot of attention on this part of the cataract, and many of times we keep on speaking about the rock hard cataract, different techniques, different machines and parameters for the rock hard cataract. But these softer cataracts produce a greater challenge many times to all of us. The reason for that is these softer cataracts have a special character in them. They have a different grade of softness. They have a different amount of the nuclear complex. So each and every case has to be managed differently, because each and every case would present a different challenge to all of us. And we do have different techniques, but then the technique which suits to that particular case has to be applied. And during the course of the surgery, if you find that one technique is not working, you have to switch over to another technique. This is what happens with the softer cataract, because it's not easy to manage when you get into the problem with the soft cataract. Extremely soft cataract. Normally we come across with the pediatric cataract or post-vitrectomy cataract, metabolic cataracts in the diabetics, sudden onset of the cataract, a very soft cataract. So these are the cataracts which you can manage very simply. Like what you have to do is just have to do a good hydrodissection and hydrodelineation, and the whole complex comes to this anterior chamber. And with the irrigation aspiration cannula, whether it's bimanual or coaxial, you can simply aspirate these cataracts. So this is the simplest form of the cataract, where you just aspirate the whole complex of the cataract with the aspiration cannula. But then not so soft cataract. If you do not, it's not very soft cataract, but it's still soft cataract, which cannot be aspirated with the aspiration cannula. So these are the cataracts where you can simply flip out the whole complex of the cataract into the anterior chamber. So another simple way to manage these softer cataract, just flip it out. So as I'm doing here the Visco Flip. So this cataract is flipped out of the capsular bag, and then with the high vacuum and high aspiration settings, you can very simply do a phaco aspiration. You don't have to use the power here to emulsify this kind of nucleus or this kind of cataract complex. You just need to do a high aspiration mode and aspirate the whole complex of the cataract. But then this is another soft cataract, a pediatric cataract, where you have a complete complex of the cataract which has been visco flipped into the anterior chamber. And then with the phaco aspiration technique, without any phaco energy, you just go inside and hold the complex of the cataract and aspirate it simply. So you don't have to do too much of manipulation here, because since you have separated this cataractous complex from the capsular bag, it becomes so easy to aspirate, and no threat to the posterior capsule or the corneal endothelium in this situation. But if you have a soft cataract with some amount of the brittleness, then the best way is like you do a small trench at the center of the nucleus. But the idea is you don't have to make a too long trench as we do in the hard cataract. A very small trench, but you have to go deep enough to complete the nucleus part. And then you can split the cataract into two heminuclei. So this is how you can split with the second device and the phaco probe. And then it becomes very easy to draw this heminuclei with the phaco probe, and you can simply aspirate it. But the idea is like you have to split into two complete segments. So if you are able to segment the nucleus, then it becomes easy to draw this complex, the heminuclei. Like you can see that I'm drawing that second part of the nucleus, and then it becomes so easy to complete the surgery. But then if you have a soft cataract with a grade 1 or 2 nucleus, so these are the cataract we can use a simple chopping techniques. You can use the horizontal chop or terminal chop technique also in such situation, do a good axis. And then with the phaco probe, you just hold the nucleus, because here you can get the hold of the nucleus and you can chop the nucleus into two complete segments or 3 to 4 segments. But you don't have to use too much of the high phaco power or too much of vacuum. Very simply, you can use a very low parameters. You can segment the nucleus and then complete the emulsification of these free segments. It becomes so easy to complete the surgery here. Now, actually, the problem comes when you come across a soft, sticky, gummy, pre-senile or senile cataract. And these cataracts have some amount of the brittleness. So they are the real difficult cataract to emulsify, because the problem with these cataracts is neither they can be held, chopped or cracked, or nor they can be moved, flipped out of the capsular bag, and you cannot phaco aspirate also. So these are the cataracts, these are the complex cataracts which many times we come across. And then what happens, like if you are using the standard phaco technique, it results into the soft material getting aspirated with the phaco probe, and you do not get the hold of the nucleus. And if you don't get the hold of the nucleus, you cannot crack or you cannot complete the procedure of the segmentation of the nucleus. And what happens, because you've tried to embed in the nucleus, you don't get the hold, and it results into the nucleus cut through and loss of suction. So this is called as a Swiss cheesing sign. And if you use sharp choppers will cut through the soft lens and make it difficult to crack the nucleus. This is called the cheese wire effect. So what happens, because if you keep on trying repeatedly, because you will finally left with a ball of the nuclear material, which convert into a plate, and it becomes very difficult to take out that plate, because if you further at times you can hit the posterior capsule, because the phaco probe would easily go through the complex of the cataract, and you are still not able to take it out and land up into the PCR, back disruption, or jonular dehiscence. So these are the common complications you come across. So what you need basically is you need a good holding of these nuclei, a technique to hold and stabilize the soft nucleus within the capsular bag. And you need a device or a technique to split the soft nucleus without any cheese wire or Swiss cheesing effect. So we have published this T-soft technique. It's a very simple technique. The T-soft, to get hold of the soft nucleus, you have to keep these parameters, very low parameters, like low vacuum around 150 to 200 millimeter of mercury, flow around 20. Phaco power, you don't use any phaco power, but very minimal, up to 5% of the phaco power. And you have to use straight phaco tip with 0 degree or 15 degree phaco tip. And what you need to do is you need to impale the nucleus from the center and firmly and deeply in this surrounding mass. Like you have to take up maximum of the amount of the nucleus into the phaco probe. So if you impale from here, then you can get hold of the nucleus. If you get hold of the nucleus, then you can do the rest of the manipulation of the nucleus. The second important point is you need a splitter, because sharp choppers would cut through. That is called as a cheese wire effect. You don't get the cutting of the nucleus. You're not able to split. So you need something like which can split the nucleus. So we have devised this 100-degree wedge splitter. Now this splitter, actually it works like a splitter, neither like a cracker, not like a chopper. Like it's not a chopper or cracker, it's a splitter. So how this splitter would work, like when you draw it, once you hold the nucleus and you draw this splitter through the nucleus, it makes a splitting force. It gives a splitting force and split the nucleus into 2 complete segments. And this is how you get a complete splitting of the nucleus. And you can see here in this video, this is one of the soft cataract. And before you start the splitting of the nucleus, you need to do a good, a nice capsular axis of around 5 to 5.5 millimeter. This is how you start the capsular axis from the center. So axis is very important because you do not get into the very large axis also or very small axis. It has to be around a moderate optimum axis of around 5 to 5.5 millimeter. So that is ideal axis for the soft cataract, because you don't need very large axis also. And once the axis is complete, you need to do a good hydrodissection, because you need to do a cortical cleaving hydrodissection. So this is important, like a cortical cleaving hydrodissection, so that you completely separate the cataract complex from the capsular bag. And then you can confirm by rotation that you have separated it. Now coming to the T-soft techniques, so you can see here, because I have entered the phaco probe, and this is the splitter which I'm going to use to split the soft nucleus. And the splitter has to go around the nucleus. This is important because unless you take it around, you won't be able to split the nucleus. So this is how you need to split. So you can see here the phaco probe with a very low phaco parameters. You just take maximum amount of the nucleus into the phaco probe and hold it, draw it, and then you hook the splitter. So once you hook the splitter is going to split the nucleus into 2 segments. This is how you get the complete 2 segmentation of the nucleus. Another case, you go slowly and split the nucleus. If you are able to split the nucleus, then the handling of these heminuclei becomes very easy. And then you can very easily draw these heminuclei into the phaco probe and aspirate, or phaco aspirate, or just simply aspirate. So another case, you can see how you can split these soft nuclei. This is how you split. So important point is you need to get the hold of the nucleus, because the hold of the nucleus you can get only like if you have a very low parameter. If you use a very high parameter, the phaco probe is going to go through the nucleus and you're going to get the cut through and loss of suction. You won't be able to hold the nucleus. So very low parameter, rather you can use the epinucleus parameter also to hold the nucleus and then split. So this is how you can split these various different kind of soft nuclei. You can see here, this is a little firmer nucleus. So once you complete the splitting of the nucleus, then these heminuclei, as you can see here, can be very simply drawn. So drawn onto the phaco probe, and then you can complete the phaco aspiration or emulsification of these softer nuclei. So this is how you get these free pieces on the phaco probe and you can aspirate. So you don't have to do too much of manipulation, like you too much of drawing, dragging these pieces from
Dr.
the
Rajendra, can we have it 1 minute, please?
Yeah, it's final now. So this is how you complete. And so to conclude, with cataract surgery, slowly but surely moving towards refractive lens surgery, ophthalmologists, we are going to see more and more of these soft lenses slated for the removal in the next few years. T-soft represent a simple, safe, and easy strategy for controlled nuclear division. So it's important to divide the nucleus, mobilization and emulsification within the capsular bag in cases of sticky, gummy, soft cataract with some brittle lens, especially the adult and the senile soft cataract with good reproducibility. 100-degree wedge splitter with the round olive tip, because it's an olive tip, so you can hook it around the nucleus and split the nucleus. It makes surgical maneuver much easier and facilitates the overall procedure with higher level of efficiency and safety. Thank you very much.
Thank you very much, Dr. Prasad. We are exactly on time. We have 5 minutes for discussion, and we can have a discussion from the panelists and the co-moderator. I just want to ask Dr. Sajdev about his thoughts about the soft cataract. Excellent presentation from Dr. Prasad.
Yeah, so Rajendra Prasad, an excellent presentation as always. So soft cataract, I would say, is as difficult as a hard cataract. At times you are taken aback, and youngsters feel that, and they normally cut through. Now, the basic idea in managing a soft cataract, Dr. Rajendra Prasad, is to actually delineate the nucleus very well, and then you can do the spring technique, or you can do the carousel technique as you want, or you can try to, even if it is a little harder, you can also do a slight chop with a blunt chopper. So even if you do a pupillary plane phaco, that does not matter, because you are hardly using, with the newer machines, you're using a good fluidics and a good vacuum, so you are hardly using any phaco power. The key idea here is that you should be careful not to go to the extreme periphery with the phacoemulsification probe, because that is where you are going to get, you're going to go through the nucleus and possibly get a posterior capsular rent. So identify the planes, be very careful, good hydrodissection, good hydrodelineation, try to sculpt the center portion and then just flip it around, and you can, so there are several ways to skin a soft cataract, but the only thing is that you need to be very, very careful with your energy. It's maybe you can even do it with a epinuclear setting. That's something very, very important, and the parameters should again be a little lower as compared to what you use in a hard cataract.
Thank you. So the key is hydration in soft cataracts, hydration, and hydrodelineation, hydrodissection. Dr. Ashraf, did you want to say a comment?
Yeah, I can about the soft cataract. Most people say that soft cataract is the easiest cataract, but the soft cataract is the difficult form. Complication always happen from soft cataract. Hard cataract can go okay because you can hold the nucleus perfectly in hard cataract. I have a question about the FEM2 cataract that Dr. Kathleen did. I want to ask Dr. Mahibal. This is a very tilted, I saw the pictures, very tilted lens. So what's your parameters or setting when you do a flex for these highly tilted lenses? How you set the anterior axis for these cases? Because you can end by when you finish your FEM2, you can see that the axis is not complete.
Okay, so I think what she showed, and one particular observation, she's possibly not here. One observation that you would have seen was that when she was showing the tilt of the lens, and she was showing a big gap between the iris and the lens, there was actually vitreous coming through. If you could see, so there was a tag of vitreous that was coming through. So you have to pump up the energy that you want, but that is in the periphery. The biggest thing that you have, like I'm used to the catalyst system, you can center the capsulotomy on the scanned capsule. You can center it on the pupil, and you can manually set it. So actually, if you are using a retractor and if there is subluxation, you can actually move the capsulotomy towards the other side so that when it becomes centered after the CTR has been put or a Ahmed segment has been put, so that it becomes central. So that is the first important thing. Pumping up the energy slightly for the capsulotomy is the other thing. The third thing that happens is that the OCT gives you fantastic delineation of the capsular edge. And like I was showing in the posterior capsule, these three bubbles that you have to actually, so you can move any 1, 2, or 3. Similarly, on the interior capsule, you can move them so that you can have the capsulotomy right on the tilt of the lens. But if the tilt of the lens is more, then there is no way that you can do a capsulotomy. So femto laser again is a fantastic tool for subluxation. The only difference that I would have from her is that I would also follow a pars plana approach in this particular case. After doing the femto laser, I would have a 3-port pars plana approach so that because vitreous was coming, I will decompress the vitreous from the posterior side, do the cutter so that there isn't hydration and coming out of more of vitreous, because when that comes, it is going to increase the dehiscence. So that is the other approach, and we have, unfortunately, I don't have them right now, but we have done what we call as pars plana vitrectomy to get such subluxated cataracts to be done. And femto is my procedure of choice because of 1, you get a good perfect capsular axis. 2, you don't have to do maneuvering for the capsular axis. The vitreous does not come in the way of the femto cutting it. And the other important thing that you have is that the nuclear disassembly has already happened. So the parameters and the kind of stress that you cause on these zonules is much, much less if you have already done a nucleotomy with a femto. So
thank you everybody for your sharing in this symposium. We all benefited from it, and we are we ran out of time now. We are finishing in the proper time. Thank you very much for all of you for your contribution and your time. Thank you, Dr. Amri, and see you soon. And stay safe.
Thank you very much, Dr. Yahya. Thanks a lot, Dr. Mahbab, Dr. Rajendra, Dr. Ashraf, Dr. Kathleen. Thanks a lot. It was very interesting, and appreciate your time and experience, sharing with your experience with us. Thanks a lot. We hope to see you in other sessions soon.
Thank you very much.
Enjoy, Dr. Ashraf. Enjoy the time.
Thank you so much. Thank you.
Okay. Bye-bye.